I'm going to speak after Dr. Brostlowski about the non-surgical therapies for Pheochromocytoma and Paraganglioma. What I've been asked to talk to you about is, and to get you to, is understanding some of the scope of the local therapies for these tumors, such as radiation, ablation therapy, embolization therapies, and also some of the systemic therapies, which would include some therapies that you've heard about already, chemotherapy, other therapies like that. I have taken part and was very happy to take part in the major clinical trial that allowed the AZEDRA MIBG therapy to become FDA approved. So I decided to start here with what a lot of your oncologists will start at when you come to them with having made a diagnosis of Pheochromocytoma or Paraganglioma. They will go to the NCCN guidelines. NCCN guidelines are a consensus statement about all forms of cancer, and they come out with the suggestions for the primary treatment. They split it up into various subcategories. They give further suggestions about other treatment. Some of these NCCN guidelines will be related to FDA-approved medications. Others will, in fact, there's only one FDA-approved medication, so actually most of the things I'll talk about today are not FDA-approved, and NCCN guidelines will cover that. This is a rather complex, it's not quite as complex as an actual page from NCCN, but it's pretty complex, so I've decided to use this as my base slide. And this is those NCCN guidelines. This is what your oncologist is going to look at to remind him or herself of what to do next when you come to their clinic. So we've heard about the importance of resection if that is safely possible, resection for cure. I'm going to continue on with the locally unresectable group. So the locally unresectable group, continue treatment of symptoms, which is with the symptoms would be the hypertension and the palpitations, etc., that we've heard about, using alpha blocker medications and beta blocker medications and others. But let's go on to the first in the NCCN guidelines, which is radiation. Now, the NCCN guidelines put radiation and what I've called here partial surgery, so subtotal surgery when surgery is not a curative. So radiation therapy has been used for a long time for Pheochromocytoma and Paraganglioma. It used to be thought that radiation was, that these tumors were not particularly sensitive to radiation, and they're certainly not as sensitive to radiation as many other tumors. However, it's become clear that these tumors are sensitive to radiation if you can get a big enough radiation dose in without injuring other tissues. And what has allowed that to become a reality then over the last few decades is the development of stereotactic radiation, image-guided radiation, you may have heard terminology, gamma knife radiation, saber radiation. So this is using very sophisticated imaging with novel forms of radiation with linear accelerator particles, photon beam radiation. All of these technological advances have allowed the radiation oncologists to be able to deliver radiation into the tumor with less radiation impact in the surrounding. Now, so this is what we call a meta-analysis, so a review, an extensive review of prior radiation therapy studies. And I've just picked out one section out of it, and this is from the using radiation as an initial therapy. And so this is most of these studies are from this century, and therefore they're using stereotactic radiation. And what you see with radiation therapy is that local control can be excellent. This is suggesting that local control, and the average follow-up here was 5 years. Local control appears excellent. Now, there's a caveat to that. The caveat is that many of these tumors grow incredibly slowly. So local control means that it's the same as it was in the CT scan the last 6 months. So is that is that in and of itself a great thing? Well, no, it's not in and of itself a great thing. You see that the regression of the tumor, actual shrinkage of the tumor, is slightly less impressive than local control. But also there's with radiation therapy and in other studies, we see that in certain areas radiation can certainly cut down in terms of localized pain and localized complications, and even to some extent decrease the adrenaline, noradrenaline. This set of studies was from head and neck paragangliomas, and head and neck paragangliomas has had a lot more radiation therapy than body paragangliomas, simply because it's technically, at least the way I, as a non-radiation oncologist, think of it, it's technically more easy to get at and get the radiation in the areas that you want it to without going through many inches of tissue. However, whoa, I've broken the internet. Oh. All right, we're back. There are studies, and this is another review of 3 studies from Mayo, NIH, and Dr. Fishbein when she was in Pennsylvania, relating to use of stereotactic radiation for non-head and neck tumors. And what you see here is, again, the radiographic control of the tumor can be quite significant, holding the tumor steady. Symptom improvement also can be quite significant. Now, I guess the majority of 70 to 80% of these were related to bone metastatic disease, and radiation has for a long time been known to be an excellent modality to decrease pain related to bone metastatic disease. But there were also other liver tumors in this group, and some soft tissue tumors. So I should just, before going on, so the type of tumors that we would think about for radiation would be tumors that are not amenable to safe surgical removal, tumors in critical places like impinging on the spinal cord, tumors that are less than 3 or 4 centimeters, tumors that don't take up MIBG or dotatate, as we'll talk about in a moment. So let's go on to the next section on the NCCN guidelines, AZEDRA. I'm going to, until July the 30th, there was no FDA-approved medication for these tumors. So this was a major breakthrough to actually bring this to the FDA and present them with data that was convincing enough to get FDA approval for this. One of the things that you may notice as I go through other studies is that there are many case reports, there are many studies with very small numbers of people, so having prospective studies like this was a major effort. You've seen this picture before. This is what it looks like. The molecule is a lookalike for norepinephrine or noradrenaline, and it gets taken up into the noradrenaline producing cells, just like noradrenaline does, but it has this payload on it, the iodine-131, which is what is the toxic agent. And Dr. Pasek has shown you the sort of differences in synthesis, but I think this is a great pictorial of this. This is what 500 millicuries, a full dose of AZEDRA, looks like. This is what the equivalent dose of conventional or old MIBG looks like. So this has 31 milligrams of mostly non-radioactive substance in it. And the problem with that, and the reason that I like this one so much more than using that one, is that when you put that into a person, all of that non-radioactive substance is A, not doing any benefit for the tumor, and B, it's inhibiting the ability of normal adrenergic tissue to clear out noradrenaline out of the body. Nerves secrete noradrenaline. Noradrenaline does its business, increasing heart rate or decreasing heart rate, and then noradrenaline is taken back up into the secreting neuron. This stuff here, when you inject that, it blocks up all of the ability of the normal cells to take up the noradrenaline again. So you have high noradrenaline levels and can develop significant high blood pressure at the time of injection, which we don't see here. So what are some of the data? These are the data from the newest trial. This is putting together all of the data from prior conventional MIBG use. And what you see here is that with MIBG use, basically about half of the patients are stable, a quarter of the patients have a partial response. In terms of the newer study, essentially a quarter of the patients have a partial response in terms of decreasing size. 2/3 of the patients have stable disease. So looking sort of equivalent to the old stuff there, but with the less complications of high blood pressure once you're injecting the medication. Looking at whether MIBG or AZEDRA can decrease adrenaline levels. I'm thankful to Dr. Chowdhury from Progenics for providing me with the newest data. Basically, about half of the patients had decrease in their adrenaline or noradrenaline or its byproducts. About a quarter had normalization of that, and about a quarter had stable disease, whereas with the conventional MIBG, about a half had a partial response, smaller numbers for full response. So that's MIBG and AZEDRA, which is a great new availability of having that. We've mentioned gallium dotatate PET scans, and the NCCN guidelines suggest that if a gallium dotatate PET scan is positive, that one could consider PRRT, peptide radioreceptor therapy. Now, LUTATHERA is radioactive octreotide, essentially, or radioactive dotatate with lutetium on it. LUTATHERA is FDA approved for other neuroendocrine tumors, specifically the neuroendocrine tumors that we usually call carcinoid neuroendocrine tumors, starting in the small bowel, starting in the pancreas. This is a recent review article of all previous studies using PRRT. Now, I should point out that they're apart from the FDA-approved PRRT for neuroendocrine tumors, there's also another PRRT using a different radioactive substance, yttrium, and this review reviewed both of them together. The protocols are quite variable. In some places, the numbers of patients are really quite small. But down at the bottom, I've noted there that, and actually there's a typo here. This is radiographic response in percentage, not months. So progressive disease occurs in 12% of people. stable disease in 2/3, and a mild or partial response in about a quarter. So just sort of eyeballing the numbers actually look very like the numbers from AZEDRA. 2/3 of the patients have a response. 1/4 of the 2/3 of the patients have stable disease. 1/4 of the patients have a decrease. So suggesting some similar response. There are some differences in side effect profile, and I've just put the side effect profile of the new MIBG, the AZEDRA, and taken out the similar side effect profile of LUTATHERA. So the big difference is the amount of hematological issues that occur with AZEDRA versus that occurring with LUTATHERA. And this is a real difference. The initial infusion of LUTATHERA, at least in this study, was associated with significantly more nausea and vomiting, although that has decreased since some changes in that protocol. Just to show you a pictorial of what happens in terms of blood counts, this is platelet number in patients receiving LUTATHERA therapy. So these are patients with carcinoid tumors of the small bowel, and you can see that with each LUTATHERA therapy, there's some decrease in the platelet count, but the platelet count gets to about 30% lower than what it usually is. What happens if you look at the data from AZEDRA? There's a much more significant drop of platelets and also other blood counts with the nadir, with the lowest point being sort of 4 to 6 weeks into the process. So in previous MIBG studies using different higher doses of MIBG than were used for AZEDRA, the people had to have bone marrow removed just in case they needed bone marrow reinstallation, but that was not used in this, it was not needed for the AZEDRA study. But about a quarter of patients needed either a platelet transfusion or some form of assistance with their blood counts to achieve better blood counts. Other important difference between AZEDRA and LUTATHERA going forward, and this is assuming that patients have a choice in that both their MIBG and their gallium dotatate PET scan is the same. AZEDRA is going to require 3 or 4 nights in a room like this, which is paper covered, lead shielding. It's quite a very boring time for 3 or 4 days. No visitors. Sometimes we need to change medications to allow patients to get AZEDRA. LUTATHERA and other PRRTs, they're given in open room without shielding, no required stay, no medication changes. But importantly, we don't have the specific. We don't have the data on LUTATHERA, and so it's studies like Dr. Pachek's study in NIH that will generate the data for PRRT. There are other PRRT trials. There's a PRRT trial starting in children that will be accessible for people with Pheochromocytoma paraganglioma out of Iowa and Ohio. We also, at Iowa, we have PRRT trials with both yttrium-90 and yttrium plus MIBG combinations. So you'll tell me about time. That's what you said before. Okay, positive gallium scan. Positive gallium scan, consider octreotide or lanreotide. So getting data on to support that recommendation is difficult. I find that there are 10 publications in the medical literature. The largest series is 13 patients. Many of them are single patients. So there are many case reports where there's a positive effect of the octreotide or lanreotide, but the larger series so far are negative. So this is one of the reports of a patient given octreotide for a week, a person who had a catecholamine secreting carotid body tumor. And what you see here is norepinephrine. During the treatment with octreotide for a week, norepinephrine falls right down, almost to normal. Impressive. Chromogranin A, you heard from Dr. Fishbein, it's used as a marker for these tumors. So very impressive. And there are multiple sort of case reports of similar nature. However, there are other studies, such as this study from France, where people were given 3 months of the long-acting octreotide and were tested for either an effect of their blood pressure before or after, no difference, an effect on their adrenaline levels, no difference before or after, no difference before or after on the chromogranin, slight increase in their blood sugar. So difficult to know. What I do in my own practice is patients who have difficult to control symptoms, I will give them a trial of a 1 week of short-acting octreotide. If that is helpful, I will continue and perhaps put them on long-acting octreotide. I do not consider this a medication I do not consider that there's data that shows that this will stabilize their tumors, unlike the situation with other neuroendocrine tumors, carcinoid tumors, where that data clearly is present. I noticed that there's a lanreotide trial starting out of New York, so maybe we'll get an answer as to whether lanreotide actually does anything. Clinical trials, really important, because as I mentioned, apart from this, there's no other definitive FDA-approved medication. So getting into clinical trials is very important, and I'm going to leave that. We've got a talk on research. So I'm going to go on with chemotherapy. Chemotherapy, the multiple chemotherapeutic agents have been used in the past. When would we use chemotherapy? Well, we would consider chemotherapy for tumors that are rapidly growing, that do not have the MIBG or gallium dotatate positivity, that are not accessible to surgery, that are multiple. Now, again, the data on chemotherapies is very poor, and this is again a manifestation of it being a rare disease. It's also a sort of a shout out for the medical community and perhaps groups like this to really try and get everybody registered, get them into some sort of central registry so that we actually can follow many people are getting CVD, cyclophosphamide, vincristine, dacarbazine, but we don't have any central documentation of that, so we have no way of capturing that data. So this is an analysis of 4 studies using this medication set, 50 patients involved, retrospective studies, response rate, about 37% had a partial response, a few people had a complete response, and stable disease in this group actually is meaningful because the only people who got chemotherapy were people who had progression. Similarly, from the same analysis, looking back at 2 studies and the effect of CVD chemotherapy on the adrenaline levels, 40% getting partial response. Now this response did not last that long, but it was present. Temozolomide therapy, There are multiple chemotherapies that have been used. Temozolomide is related to dacarbazine. So, but this was an interesting paper in that it was a look at 15 patients who had progressive metastatic Pheochromocytoma paraganglioma, 2/3 of which had SDHB, and overall they were on the medication an average of 13 months before there was progression of disease. But actually, when they split up the numbers, the people who had SDHB got a recurrent disease or regrowth at an average of 19 months, whereas the people who didn't have SDHB got a very early recurrence. So this underscores, the importance of what Dr. Pachak does, Fishbein does, and my colleague from Stanford. The goal here is to discover the genetics and the mechanisms such that we can then move to giving medications that are tailored to specific genetic groups. That has never been really done before. This is a publication that clearly demonstrates that these genes have an impact in terms of the therapy that should be used. Tyrosine kinase inhibitors. This is a large group of medications that have been used in multiple other tumors, and I'm not going to talk about it that much because all of these are under clinical trial. I will mention that there are clinical trials on both sunitinib and cabozantinib, 2 medications in this group. They are already FDA approved for renal cell carcinoma, pancreatic neuroendocrine tumor, certain other things, currently in clinical trial, but they are used off-label. I'm impressed by, in their use, I'm reminded of this letter to the editor that Dr. Fishbein and colleague wrote a number of years ago. These medications as a class tend to increase blood pressure, which can make things. I've broken the internet again. It's a sign. Okay, all right. So one thing that wasn't mentioned on the NCCN guidelines, and nobody can see it, is local ablation and embolization procedures. This is a review from Mayo Clinic using radiofrequency ablation and cryoablation, showing that they did ablation studies mainly in bone and liver. The lesions were all 2 centimeters, 3 centimeters. Those would be the type of lesions that would improve. Local control is very good with this, and they followed up for 26 months and showed that there was local control. Finally, hepatic artery embolization. A couple of things. Hepatic artery embolization is where an interventional radiologist puts a catheter up the groin into the liver and can then inject substances to clot off blood vessels in liver arteries that are feeding tumors. Now, there are various forms of. I should point out that this seems to be a particularly Asian thing to do. Almost all of these papers have been from Japan. This is TACE is transarterial chemoembolization. There is also TAE, which is transarterial embolization. They do show that the catecholamines, which were all increased before, have decreased afterwards. But you see that in almost all of these case reports that there's significant hypertension issues, and this is just one particular gentleman who had a lesion in his liver, had been treated with phenoxybenzamine, so had been prepared adequately with normal blood pressure going into it, but as soon as he got this arterial embolization, that got him passage to the intensive care unit and some very high blood pressures. Done it again. So which therapy for Pheo-Para? I've given you a lot of therapies. I knew I was coming after a surgeon, so I put that right on top. One of the shout-outs that I would give here is that there's a huge role for a multidisciplinary tumor board. I am an endocrinologist. I know nothing about, I have never administered most of these things. So it's so critical that the physician group can sit together with a surgeon and people who are understanding the clinical trials, a medical oncologist, people from nuclear medicine to come up and to help you with the best plan. And I'm sorry I went over time. This is our group. Thank you again for inviting me.